Good morning, everyone, and thank you all for joining us for another TIRO multidisciplinary seminar. As always, I want to thank you for being a part of our program. We have mentioned over the past few weeks here that we are now into our 5th year of programming. As always, we welcome your questions and certainly, hopefully, we'll be able to entertain them by the end of this session. I'd like to go ahead and share my screen. Would like to thank my co-authors on this manuscript that was published in European Thyroid Journal, of which Dr. Shaha, who's here this morning, is on that author list. I am a member of the TIRO Medical Advisory Board. So I'm joined this morning by two esteemed discussants. The first is Dr. Bruce Wenig, who is chairman and senior member in the Department of Pathology at Moffitt Cancer Center. He assumed this position in 2016 after a 12-year stint as chairman of the Department of Pathology at Continuum Cancer Centers, where he and I overlapped for those 12 years. Dr. Wenig has published extensively in the field of head and neck and thyroid and parathyroid pathology. In addition to his numerous articles and 85 book chapters, his textbook, Atlas of Head and Neck Pathology, is now, Bruce, correct me if I'm wrong, it's in its 4th edition?
That's correct.
You know, I actually just want to tell you, I think I like the first edition better. It was a little bit lighter, a little bit easier to carry around. This 4th edition is actually very, very cumbersome. I've actually gotten 2 hernias by lugging this around here. It is undoubtedly the definitive resource for head and neck pathology. And I will editorialize and say that whenever I talk about Bruce, I usually refer to the Mount Rushmore of head and neck pathologists, where Bruce's image will, if it's not already there, will undoubtedly be there at some point in the future. Bruce, you're going to have to send me quite a bit of money for having said that, but that's okay.
Only if you buy 10 more books.
Oh, I'd like to introduce Dr. Greg Randolph, who needs no introduction. He is professor of otolaryngology, head and neck surgery, and is the John Bertucci Endowed Chair in Thyroid Surgical Oncology at Harvard Medical School. He has published 2 major textbooks in the field, one, Surgery of the Thyroid and Parathyroid Glands, and the other focusing on the recurrent and superior laryngeal nerves. His clinical research, as everybody knows who is involved in this area, has been related to the preservation of vocal cord function during thyroid and parathyroid surgery. He has directed the World Congress on Thyroid Cancer, as well as the Harvard Thyroid Parathyroid courses, both of which have been hugely successful. And I dare say he will befriend me if I don't mention that the upcoming World Congress is scheduled in Boston for mid-July. Greg, anything else you want to mention about that?
No, but despite your Wenig-induced hernias, we do expect you up in Boston despite that. So put on your belt or whatever you need and come on up.
I will be recovering from those surgeries, I'm sure. So, well, before getting into the meat of this, I do want to acknowledge that both of my discussants this morning do have loyalties to their respective football teams. And even though Dr. Wenig has moved to Florida, he remains a New York Giants fan. Icarus made a tragic mistake of flying too close to the sun. And at risk of replicating that mistake, I do want to highlight 2 very important things. One of them, this is a scene from this year's 2025 Super Bowl. And if I need to remind our listeners, Dr. Randolph and Dr. Wenig, this was won by the Philadelphia Eagles. But more importantly, I do want to identify a source of great pain for Dr. Wenig, which is the trading of Saquon Barkley to the Philadelphia Eagles. Bruce, do you want to see that move again, or? what I'm
I've seen it too many times.
Well, I'm sure it's reminiscent of how the moves that I showed when you were in frozen section and how I got my slides up to the front of the line there. It seemed that somehow, at the complaints of other surgeons, I always managed to get mine done first here. But I don't want to leave Dr. Randolph wondering if I was not going to bring up this particular play from the 2018 Super Bowl. When with 4th and 1, Nick Foles, who was the backup quarterback, actually became a wide receiver. 4th and 1 on the goal line. And Greg, I'm happy to play this one over and over again.
Yeah, thank you. That's wonderful. I appreciate that. Thank you.
Okay. Well, that was actually not the reason why I asked them to be here, but I couldn't resist the temptation. So in getting
And you want us to favorably comment on your paper now? Is that your plan?
Well, I referred to both of you as friends and colleagues, and I may have to drop the friendship at the end of this. So, but getting into the meat of this, the American Thyroid Association published an article. It was from the Surgical Affairs Committee, I believe, back in 2012. And what they stated was that surgical input is integral to decision-making in thyroid cancer, but the content and quality of information flow can differ widely among practitioners concerning pre-operative surgical findings and adjuvant care. And what they stated back in 2012, which is still true today, is that there is not yet a universally accepted model for effectively communicating these critical pieces of data between the various healthcare providers involved in the management of thyroid cancer patients. And that interdisciplinary communication is especially important in thyroid cancer since the pre- and intraoperative findings often complement histologic findings described on the path report that influence stratification, adjuvant treatment, and follow-up strategies. And so in that article, there were a series of preoperative data points, intraoperative, and then postoperative data points that were considered fundamental to this communication flow in order to ensure that there was a comprehensive understanding of what the nature of a particular patient's disease process is or was. What was interestingly highlighted was the importance of recording information within the first 24 hours in order to achieve the most accurate recall. And this article by Novitsky identified that as one gets past that 24-hour mark, the accuracy of operative reports decline. I think that's a really important point. And then went on to state that regardless of who will be providing immediate care and long-term surveillance for patients with thyroid cancer, the importance of communication is essential. So where are the various sites where perioperative information is stored? And it's quite diverse. It's in the outpatient clinic record, referral letters, cytology reports, obviously the dictated operative note, operative diagrams, molecular analysis. But I will say that there is one place where that information, the most important information, resides. Dr. Wenig might state that this is actually a scary place, but it is the truth. This is where information resides about the true understanding of what a patient's tumor biology is represent. And it's important to identify, and this is really arguably the most important document. It's that postoperative pathology report. It's not the surgeon's operative note, and it's none of the other pieces of information noted above. That is the most important document that follows a patient through their cancer journey. And the importance of that is undeniably to achieve accurate and comprehensive information flow for AJCC staging, risk of recurrence classification, and a risk-adapted approach to postoperative care, which is really the mantra for contemporary thyroid cancer management. And this is something I'm going to ask Dr. Wenig to comment on at the end. And that is to identify this information gap, which is what the surgeon saw in the operating room as it compares with what the pathologist sees under the microscope. So what are the sources of inaccuracy in a path report, primarily for invasive thyroid cancer? One of them is the failure of the surgeon to make anatomic findings crystal clear in the operative note. It's the failure of a pathologist to know to actually look at the operative report for additional information. And it would be important to hear from Dr. Wenig at the end what triggers his decision that he's got to go further and actually look at an op note. I can't imagine that every pathologist will seek out a surgeon's op note in order to understand what was found. And I do say that there is this level of complacency that pathologists get into because of the prevalence of low-risk disease that probably does not require going further in order to understand what was actually identified. And then interestingly, an article that came out of Sloan Kettering by Baxi et al. Looked at how well pathologists actually understand key information that's in an operative note, and identified both from an endocrinologist as well as from a pathologist perspective some of the challenges of comprehending information from that operative note. And so we conducted this study and concluded that an anatomic checklist is important because it provides for this fundamental need for a pathologist to understand what was found and eliminates the need for a pathologist to actually have to seek out that operative note and to go through it and actually waste time in the process. And one of the things which I mentioned is that there's no real trigger for a pathologist to know when they need to search for additional information. And at this time, I think there is ambiguity about what actually constitutes invasive disease of a structure. Is it only what the pathologist sees under the microscope or what the surgeon observes in the course of removing a cancer? And what's the interface and when is invasive disease actually determined? The byproduct of the creation of an anatomic checklist is to establish a mechanism for capturing data that indicates what structure was involved and what the depth of invasion, so that we can achieve the desired goal of doing outcomes research in this particular area. And so we wanted to establish a standardized means of communication to recognize and realize that accurate staging of thyroid cancer is fundamentally based on this exchange of information between surgeon and pathologist, and recognition that the degree of invasion is not a binary determination. And with an attempt for us to discern whether involvement of different structures that are currently staged as T4A, that includes the RLN, the trachea, the esophagus, subcutaneous tissue, whether they are all the same and have the same prognostic implications, and whether or not the involvement of a structure in terms of the depth of involvement, such as I'll show in just a moment, whether that needs to be looked at more critically. And so I show these three examples of recurrent laryngeal nerve involvement here. In the first example on the upper left, you see this is an exophytic nodule coming off the posterior surface of the thyroid, and this is the RLN that is tracking right adjacent to that. I had to use a 15 blade in order to separate this sharply. I am sure that I was leaving epinurium behind in the specimen, but there is no way that a pathologist, not even Bruce Wenig, would be able to identify that this degree of involvement was there. One might argue that even this on the upper right-hand corner, where there's a clear transition in terms of what the recurrent laryngeal nerve looks like grossly as it goes into the area where it is involved by tumor. And similarly, down in the lower right, where the nerve coming up as it's heading towards the joint transitions dramatically in its appearance. And the question becomes, are all of these different scenarios the same, that they would all be classified the same as T4A disease? And so this is not a novel concept. Back in 2010, actually 2 years prior to that ATA report that I referenced, Ito and his colleagues in Japan talked about an intraoperative staging system. And they noted that the use of intraoperative findings related to extrathyroidal and extranodal extension was of vital importance. And they went further and graded the degree of an tumor extension into minimal versus maximal, and talked about to what extent different structures had to be resected in order to be able to clear that disease. And so they established what they refer to as an I stage, short for intraoperative stage, which they felt better characterized disease biology and better predicted disease prognosis. And I need only harken back to the work at Greg's institution done by the pathologist Shin in an article where he looked at staging the degree of tracheal involvement at different stages here that are shown in stage 1, where there was just superficial involvement of the trachea. Stage 2 was beginning of invasion through the fascial planes between tracheal rings. Stage 3 was submucosal involvement that was not evident to the eye in somebody doing an endoscopy. And then finally, stage 4, gross invasion of the tracheal lumen. And in the 22 cases, it was clear that there was a difference from a prognostic perspective as to what the implications of the degree of involvement was. And so in the patients who had stage 1, 2, or 3 disease, there were 11 patients, none of whom succumbed to their disease in the first 5 years. One died after 5 years. But in the 11 patients who had stage 4 disease, shown in the lower right with invasion of the tracheal lumen, there were 5 of 11 patients who succumbed to their disease and 1 additional patient. And so a clear differential between the degree of involvement and how well that predicted that patient's disease-free survival. And there was a difference noted on other parameters that stage 1 through 3 had a 36% positive resection margin and lymph node involvement, and a much higher level of positive resection margins and lymph node involvement for stage 4 disease. So just for our listeners, just to refresh your memory, stage T3B disease involves the strap muscles. Stage 4A involves the structures which I just mentioned, the trachea, the esophagus, the recurrent laryngeal nerve, the subcutaneous tissue. And stage 4B involves the great vessels and prevertebral fascia. And the impact of a T4 designation is evident on the disease-specific survival, as shown in these curves. As important as age is, that we all know, T4 disease has a significant impact on disease-free survival, and therefore this is a population of patients who are worthy of our study and further analysis. So let me get back to our study and talk a little bit about the design of this anatomic checklist, which is really intended to supplement the CAP protocol. And we did this through critical analysis, feedback, modification, and consensus building. And it was intended to capture important information at various points, including, which is something that is not recognized by many clinicians, that HACC staging actually includes data capture up to 4 months following surgery. And so what we wanted to do was pave the way for critical information in that final pathology report that gives us clear an understanding of disease biology and a mechanism for accurate stage AJCC staging, accurate assignment of baseline risk of recurrent, and information regarding gross or microscopic residual disease. Again, something that a pathologist cannot determine by looking at a specimen under the microscope. And so this is that anatomic checklist that we created. The first part of this has patient-specific information that we do not store on the TIRO website. And I'll talk about that in just a moment. The second part of this is basic information that we classify as the minimum data set. Was the outcome of the resection in R0, R1, or R2? Was this done in the primary or recurrent setting? Was is there evidence of distant disease that the pathologist needs to understand? And then specific AJCC criteria for accurate staging that's shown in these data points. And then same holds true for additional information for risk of recurrence classification. And then finally, information that's most likely in the clinical record that would not be available to the pathologist, but of vital importance if molecular testing was done as prior workup, whether the vocal cords are functional preoperatively, and whether or not the patient had received any previous treatment for their disease. And so one might look at first glance at this and say, my God, this is this staging system would never fly. Nobody can understand this. There is an actual clear understanding and a logic to how we went about creating this, breaking down the anatomic sites into laryngotracheal, bone, nerve, pharyngoesophagus, artery and vein, and muscle, and then putting in various anatomic subsites that you see in this column here, and then a subscript and a superscript that in most instances, the superscript reflects the degree of involvement and the subscript indicates which vascular structure was involved. Muscle involvement is binary. We don't use a 0 or 1 superscript. It's either the muscles involved or not. The trachea, we add the number of tracheal rings that were identified by the surgeon as being involved. And the pharyngoesophagus, the 0 refers to muscularis involvement and 1 refers to transmural resection. And importantly, we include REC for recurrent disease. And so these are the diagrams that go along with each of these anatomic stages. That here is laryngotracheal with the various components. And here you see in the final column the degree of involvement, subperitoneal versus through and through resection, the number of tracheal rings. This is importantly nerve involvement, whether it involves just the epineurium or all or part of the nerve. The pharyngoesophagus broken down between the pharynx, the esophagus, and whether or not it's muscularis or a through and through defect that is created. Involvement of muscle, which as I mentioned, does not have a superscript. It is a binary determination. And then finally, vascular, to identify through a subscript which of the major vessels was involved and whether it's adventitial or a involvement of the wall requiring resection. And so we went back, this was all stimulated by looking at our the results of how accurate a pathologist was in determining the stage of disease that the surgeon knew about and how well the pathologist was able to capture this information. There were 2 surgeons at our institution who manage invasive thyroid cancer. And for surgeon A, 13 of the operative notes that were not accompanied by a checklist 12 of 13 were inaccurately staged. When he transitioned and used the checklist routinely, 6 of 6 were staged accurately. I became frustrated after one case and it was evident that it was important to have a new and different mechanism for translating information about what I knew I identified in the operating room and what the pathologist could not see. And so for the last 9 of my invasive thyroid cancer cases identified that were in this study, all 9 were accurately staged accordingly. And in recurrent thyroid cancer, the AJCC does not require staging. All of those cases that were included in the study were inaccurately classified with respect to the disease that was actually resected. And so the most common unreported structures included the muscularis, strap muscle, recurrent laryngeal nerve in 4, cricothyroid muscle, and the tracheal perichondrium in 1 case. And here's a good example. This is a patient who underwent total thyroidectomy, resection of the internal jugular vein, and here's that is readily evident. Here's the jugular vein sitting on the surface of a metastatic node. The cervical esophageal muscularis, you can actually see it here, that the interface between the tumor and the esophagus was compromised. No surprise that the RLM was involved and that this interface required resection of perichondrium. So this is staged T4A, N1B disease, MX, but there's no way in anyone looking at that staging to truly comprehend what was actually removed and what the extent of the disease entailed, unless one can actually incorporate this degree of anatomic information. These were the recurrent cases, and gross nerve invasion was missed in 5, esophageal musculature in 2, as was perichondrium, and actually the carotid artery was missed in the final path report for this recurrent case of invasive thyroid cancer. And if you look at this particular case of a recurrent disease, this would involve resection of this recurrence that was sitting adjacent to the esophagus. It involved resection of the RLN and a full thickness resection of the esophageal wall, which was repaired over a bougie. And so one would have to go through this, but in detail to try to understand by looking at the final pathology report and the op note. But if one were to stage this accordingly to our staging system or our classification system, it becomes readily evident what was done in a neat way and a concise and very transparent way of doing that. So what does this study show? It shows that there is enhanced accuracy of staging when we do incorporate a checklist, and we have gone on to adopt the use of this checklist in all primary and recurrent cases. What are the challenges of adoption? And I'm going to ask both Dr. Wenig and Dr. Randolph to comment on this. One of them, and anybody looking at this saying, oh, gosh, this is going to take me forever to do this. How am I going to ever learn yet one more way to stratify anatomically? And that is why we included all of the illustrative diagrams to make it clear. So let me show you actually how this happens. And so many of you who are listening this morning are familiar with the TIRO website, which is at TIRO.expert. This is that complicated case that I showed you of that we staged and classified in this way. And so when you come on to the TIRO website, you go up to the upper right corner, you go under care recommendations, you get to analysis tools. This is actually real time, and you can scroll down and you can print out the checklist and fill it out and hand it to your pathologist, or you can go through and actually choose the appropriate items and then have the system go ahead and classify the disease appropriately. And here you can see each of the various line items that I showed you. indicating the extent of resection on each of the anatomic structures, and providing intraoperative information or information from intraoperative findings to be able to help the pathologist to clearly understand what was found and what was done during the procedure and what was identified prior to surgery, including the status of the recurrent laryngeal nerves, and whether any previous therapy had been instituted, where the structures that were involved were identified. Here's the tracheal involvement that was subperichondrial. There were 2 rings involved in that resection. As far as the recurrent laryngeal nerve, all of it was resected. This was not in an epineurial layer. As far as the pharyngoesophagus, it was the esophagus that required resection of the muscularis. And then finally, as far as the internal jugular vein, this was resected in its entirety, as shown here. So once you hit the submit button, this system automatically provides you with the necessary information, and a report is generated immediately that gives all of the information that you put into the system as you were filling out the form, which is then able to be transferred to the pathologist for them to clearly understand what you found. And so here's each one of those line items clearly demonstrating what was identified in the at the time of surgery, what layer was resected, and making this clear. We even, for the sake of clarity, include a summary here, as well as the spectrum of risk of recurrence and AJCC staging. So the time factor. One of the keys to looking at adoption is the difference between having a pathologist to scour the operative report for relevant information, or the time for the pathologist to call the surgeon to better clarify what the surgeon found at the time of surgery. Both of those are time consuming, and as I mentioned at the outset, the trigger for a pathologist to know that they've actually got to look at that operative note in order to understand what was actually found, that's a time-consuming process. Versus the time required for the surgeon to complete and submit the anatomic checklist when the surgical details are fresh in his or her mind. What Dr. Chai and I did was to time how long it takes to fill out that checklist. And it was anywhere from 30 to 90 seconds. You do this at the end of the case. It's fresh in your mind. It's very, very straightforward. So the alternative option, what the ATA surgical committee had identified, was put at the top of your operative note key intraoperative findings, and make it clear at the very outset. And some surgeons may find that that's a better option for them, as opposed to completion of an anatomic checklist. But what you're missing in doing so is setting the stage for a research opportunity. And currently, it's impossible to retrospectively evaluate the details of T4 disease because the granularity of information is going to be very, very difficult to retrieve from a pathology report. And that adoption of a means to conduct outcome studies requires a critical first step, and that is you got to classify this, the involvement of anatomic structures if you're going to be able to try to study them. So having indexable data points sets the stage for the creation of a registry, and certainly easily sets the stage for multi-institutional collaboration in order for us to enhance understanding of this critical T4 disease, which is responsible for the majority of disease-specific mortality. And so the questions that need to be answered are, do different anatomic structural involvement have the same impact on prognosis? At the moment, they all are grouped the same. Does the extent of involvement, as I've brought up in various points during this talk, do they have the same impact on prognosis? And the only way that we're going to be able to substantiate or negate the significance of adding more granularity, to our current staging system is to study this in a granular way. We may end up saying it doesn't really matter. Whatever you classify, if you involve that structure, it has the same impact. But there's no way for us to be able to determine that unless we begin the arduous process of collecting the data and then looking at outcomes. So who are the beneficiaries of adoption of anatomic checklist? Well, the first one is the pathologist, and Dr. Wenig is going to think that I've gotten soft in my as I've gone on in years, and that I'm actually worried about the pathologist and them and saving them time. But I do think that as I look at this and really understand what's required, it is vitally important that the surgeon take on the mandate that they provide this information as clearly as possible in order to get the most accurate staging and allow for the most risk-adapted treatment for any particular patient. Downstream providers benefit from their ability to determine with accurate risk of recurrence, the stage, the need for RAI, the degree of TSH suppression, and the rigor of postoperative follow-up. Radiologists who are looking at tracking this disease need to understand where the pain points were for the surgeon during the operation. And radiologists are not going to go back and review an operative note in order to try to get clarity. They will look at a pathology report. If that information is enclosed there, we are doing the patient and the radiologist a service. And for those patients with, and in particular for invasive thyroid cancer, if we are looking at the role of external beam, we need to be able to clearly demonstrate where the disease was most problematic. And then finally, future patients will benefit by paving the way for research and enhanced understanding of invasive disease. So I'm going to stop there, and at the risk of incurring the wrath of Dr. Wenig and Dr. Randolph, let me open this up to discussion here and welcome your comments.
So this is an incredibly valuable resource for somebody like me. And in our practice, I see thyroid cancer, I don't know about daily, but nearly daily. Most of those are primary and contained in the thyroid, but there's a fair amount of advanced invasive cancers that we see by virtue of Moffitt being a tertiary cancer center. Through trial and error over the years, I have trained myself to go into the medical record on every thyroid that I review to read the operative note. I don't go through it, in exquisite detail, but I find the pertinent information. And I started doing that because I would get phone calls or emails from surgeons, whether I understaged or overstaged based on what the pathologist was viewing and not having the pertinent intraoperative information. And only because of that did I learn that, I need to be proactive and look at this information for myself. That doesn't mean that I don't contact the surgeon, to find out if I'm reading correctly. But I have used those errors, if you will, in staging, pathologic staging, to teach myself to spend the time and look at the operative note. You're absolutely correct. It's time consuming. It's not efficient. And oftentimes it's, I have not been accurate. So, although I lose efficiency, I gain accuracy by doing that. So having a checklist like this that, can be included in almost every case, and we could talk about the adoption of that and how to do that, would be extremely valuable to me in saving time and effort and getting a more accurate impression about what has been going on intraoperatively.
So Bruce, let me challenge you for a second. You are seeing advanced disease, I'm sure.
Yes.
Your institution. Talk about the entire scope of pathologists across the country, those in community centers where the vast majority of thyroid cancer is being managed. What do you think the general practice of thyroid pathologists is? Are they as rigorous in their discipline of looking for further information to better understand disease?
I think if it's a comparable center to Moffitt, where there's subspecialty pathology sign out and organ specialty, where people are focused on head and neck and or endocrine, you probably have the level of scrutiny that I do. But if you go across the country, you need to understand the pathologist's goal is not only to be accurate, but be efficient. And when you have a stack of cases that transcend every organ system, you want to get through those cases so you're less likely to spend the time and effort going through, the operative report on most, if not all of those cases. So I would say in general, there's a low level of, and I'll use the word loosely, compliance by pathologists nationally, particularly if they're not seeing a lot of thyroid cancer on a day-to-day basis and over now and then. So low level, low volume practices that they do not spend the time and effort to do this. But if this comes with the sanction of something like CAP or AJCC, it'll force the hand of almost all pathologists to manage this correctly. So I think the guidance has to come from outside the institute, not only from the multidisciplinary team, but also national renowned organizations like AJCC and CAP.
Great. So Greg, you were a co-author on that original article now 13 years ago. What do you perceive as being the impediment to coming up with some universal method for being able to communicate so that, and again, I'm not in the business of saving Dr. Wenig time, but I do think for the sake of accuracy, what's been the impediment, do you think, to come up with some universal way here?
I agree with Bruce's comments, and I think it is that we have a workflow, and I think we don't think about how to optimize that workflow. We do what our forefathers did. So I think your work highlights first and foremost the tremendous importance, I think pathologists and radiologists will recognize, of the surgical information, the tremendously important surgical information. But right now, that surgical description of the extent of surgery that the surgeon observes is a dynamic and variably documented process, the operative. That it is then a disjoint between the pathologist, who then actually is the person who analyzes and codifies the exact extent of disease, separate, dissociated from the surgical description of disease. And it's that pathology documentation that gets into the chart and directs the patient's extent of surgery. So there is inherently a disconnect between that process. I think you're simply asking for that to be linked up, which it just hasn't been because of the process that we have. I love the diagrams though, because I think the surgical description of extent of disease varies from surgeon to surgeon, just as Bruce may acknowledge that the pathology investigation of a given specimen varies from pathologist to pathologist. Some surgeons may not know exactly where they are in the field. And I think those diagrams force a uniform and accurate understanding by the surgeon, which I don't believe is always there in the setting of invasive disease. And it forces that. I agree with you also that the benefit of this passage, this connection of surgical information to pathology also is a benefit from surgical information to radiologist. And that radiologist will harvest information in a much more robust way if there's ongoing feedback that this would provide them. I think this is, so Mark, I think the answer to that is that there is a disconnect, and a lot of your work over the years has been on disconnects in thyroid cancer patient care. Here we're talking about disconnect between surgery and pathology. There can be a disconnect between surgical postoperative care and endocrine care. There can be a disconnect between in advanced disease endocrine care and the transition to medical oncology. So I think this is just like a signature of your work over the years of trying to identify those points of transition. from surgeon to pathologist, from surgeon to endocrinologist, from endocrinologist to medical oncologist, to, we each have our own separate offices and our own separate silos, and you're just endeavoring to link us all up. I just wanted to make one last comment, and I think that one of the rationales for this is not just better surgical care, better patient care, making Bruce's days shorter, and also making the radiologist's subsequent work more accurate, but the research opportunities and the practical issues of, is perichondrial involvement the same as through and through cartilaginous invasion? We're never going to know that. With this, we could know that. And my own pet peeve about having RLN involvement in T4A, it really should be in T3B with strap muscles. We all believe that, but this would provide us the information to take the nerve out of the visceral invasive compartment and into the much less significant, more easily resected strap muscle T3B compartment, and we'd be able to harvest data that would give us this information. The last point I just want to make is that, some people that deal with lobectomies and non-aggressive cancers, benign disease and parathyroid disease may not see the rationale for this. It depends on what you do each day. Head and neck surgeons dealing with bad cancers can understand this. So you have to, I think, approach the group, perhaps the Head and Neck Society, for example, that is most aware of the problems encountered with invasive disease. And some people that are dealing with minor benign thyroid disease and parathyroid disease, it's going to be a difficult task for them to understand the importance of this. But I congratulate you. I think it's really important work, especially the research opportunities.
Well, can I add one to what Greg just said, which I wholly agree with? If you look at and tangentially, but somewhat related, if you look at the CAP protocol, it's really binary, with the recurrent laryngeal nerve, either it's involved or not involved. So if I'm reading the report that it says it's involved, but I don't know that it's just the epineurium and you spared that nerve, I may upstage that cancer. So the granularity of the CAP protocol is not as advanced as it should be. So gathering information like this may allow the next iteration or the next iteration after that of the CAP protocol to incorporate much of this data so that we properly stage those cases.
I think Bruce's comments are correct, and I think that this disconnect can't be overstated. I have resected in both malignant parathyroid disease and malignant thyroid disease recurrent laryngeal nerves. And I have not called the pathologist and reviewed my surgical details. The operative note indicated that. But I've had those specimens fail to document neural invasion when the RLN was in the specimen. So you talk about disconnect there. I took one of the major nerves in the surgery, and it was not commented on in the pathology report. And I bear part of that burden of guilt because I should have called the pathologist. I wrote it in my op note, but this disconnect is really poignant in specific circumstances.
So this brings us to a really important point. And Ashok, I'll ask you to weigh in on this as well. So Bruce, if I say in surgery that the nerve was involved, or that I felt that the muscularis of the esophagus was involved, and I took it, but you don't see it under the microscope, you're not seeing invasion of those structures. Who's right? Does this deserve T4A classification if you don't see it under the microscope?
So in those instances, I would defer to the surgical findings. Having said that, the workflow of that specimen, once it comes into pathology, I don't see it. It's grossed by the pathology assistant, and that pathology assistant may not be as familiar with the anatomic structures, or may overlook, identifying and taking the section and indicating that that's the, whatever a paraffin block is in the cassette key is the recurrent laryngeal nerve, or the esophagus, or whatever structure. So that, if I read the report and I read every gross description, and I go to your operative note and I see that there's a disconnect, I will go back to the specimen. with the PA, if possible. We're at different locations, so it makes it, even more challenging. So, I would rely on the operative findings and try to figure out what I'm missing in the specimen to clarify it in order to correlate what you've seen intraoperatively and what I need to see pathologically.
Mark,
So
that's an interesting point, and I think it's going to get more difficult, not easier, because as more advanced patients are treated initially with neoadjuvant therapy, there is as you know, a variable, significant in terms of surgical challenge, desmoplastic response to the shrinking tumor, which we do not understand just yet. It varies. It may be histology based. It may be what is the driver of the disease based. It may be what is the agent being used. It may be the duration of the agent. We don't know the dynamics that underpin that variable desmoplastic surround, but it can be ponderously difficult at surgery. And we don't know, is that speckled with tumor? Is it all retreated tumor? Is it the VEGF shut off and avascularity and scarring that occurs? So there's going to be more difficulty of the surgeon and the pathologist. That issue of your wonderful question you asked of who's right, that's going to be a much more difficult playground with neoadjuvant therapy for advanced cancers.
So whenever I'm looking for the ground truth on a topic, I usually dial 1-800-ASHOK-SHAHA. And so Ashok, tell me, we see things in the operating room and we respond to them in an effort to resect disease. Especially we have a totally different mindset when it comes to invasive thyroid cancer. So are you emphatic when you talk to Ronnie Gassane and say, Ronnie, I'm telling you, this structure was invaded, and Ronnie says, I don't see it, Ashok. Who's right? And what is the appropriate classification here?
You want the answer from Shaha or you want the answer from robot? Because
I want it from chat. I would like it from ChatGPT.
I think, the points all of you have brought are very important. And I think this is a monumental work, Mark, you have done over a number of years that you have faced the problem. And I think Bruce and Greg have done a fantastic job. The issue is, it's a responsibility of the surgeon to define the extent of the disease. If you took esophageal musculature and you don't tell Bruce, he's not going to write anything about it. He's just going to say either you have to also realize that there is a synoptic reporting system, both for the operating report and for the pathologist, and that can be very confusing. And I think as a surgeon, if you find at the end of the operation that you are not happy, you think this patient requires one kind of adjuvant treatment, I think it's a responsibility of the surgeon. The problem is, where do you write it? Do you write it on the pathology request? Do you write it in the operating report, which is generally done by the fellows in a synoptic way? So there is no way to write. And you also have to realize today, with the patient accessible to the medical records in EPIC, they are going to read every line. And they're going to challenge you, what are you writing here? You told me this, and now you are telling me totally different. So I think it is a real problem. But if I could summarize that, the surgeon must define what he found at the time of surgery. Was the nerve invaded? Was the tumor around? Did he sacrifice the nerve for a good reason? Did he leave some tumor behind, either gross or microscopic? Because those decisions are very important. And the last thing is, we need to talk to our both endocrinologists who are going to monitor the patient and manage the patient, and our pathologist. Luckily, we have been very blessed with the best pathologists. They will call us, especially if the margin is positive. Hey, what did you do? I see a margin, what Rani calls many times, the minimal positive margin or a wide field positive margin. That wide field positive margin tells me that I did not do the best surgical procedure. And when this patient will recur, I won't be able to salvage. I think those are the important issues. The question still remains, where do you put this in the medical record? Or do you keep it in your head and just talk to your colleagues in endocrine or pathology?
So let me, thank you, Asha. So let me get to that. Bruce and Greg, tell me what you think is the pathway to adoption. What needs to be done in order to create the next step here of doing something that 13 years ago was identified as being important, but has never been done? How do we get past that? Bruce, you had some thoughts about this. Maybe if you want to start off.
Well, in terms of conveying the information, it would be important to have it memorialized in the medical record and not just in an email, but something that could be referred back to, retrospectively and prospectively. I mentioned CAP protocol. It would be extremely important to get buy-in from the CAP protocol. It's not as granular as it needs to be, not only for thyroid, for other head and neck sites, but in particular the thyroid. And so once that buy-in happens and becomes part of the CAP synoptic review, then I think pathologists nationally will be forced to incorporate all this information. So in the meantime, we're reliant on, lack of efficiency, going to the operative note and trying to define all the issues that we just talked about.
Greg?
Yeah, I think, presenting this information at the World Congress in Boston that's coming up is one way of getting the information out there. I think of knowing your audience and knowing that for cancer surgeons who are dealing with more advanced cancer, perhaps the audience would be the Head and Neck Society, people that routinely deal with more advanced situations. That's the market that you want to go to. That's the people who are going to understand the need for this. And also, I think, as you and I have discussed, to entice the wider audience through a group, a multi-center study that would involve easily many advanced centers in the US and perhaps internationally, where we would accrue this information in a broader, with a broader publication with a higher N. And then with positive results from that, each of those centers would be then your apostles and would further promulgate this. Like the International Neuromonitoring Study Group on nerve monitoring. There are other features of quality, like now with technology involved, should there be a cataloging of neural monitoring information? Should that be a standard? V1 stimulation, for example, should we always do that? Now, most op notes say I use neural monitoring and I had a signal or I lost a signal, but it's a very casual, dynamic, and chaotic description. And might that be amenable to a more algorithmic approach? Now, parathyroid autofluorescence, both camera and probes, should that information be validated and be able to be retrospectively analyzed by being recorded in the op note in a similar algorithmic way that's formal and equivalent among all these different centers?
Great. Bruce, let me give you the final 1 minute here. This is clearly disparate from, I would assume, and I don't, the rest of the cancer organs, the cancers in other organ systems. It seems like this is really a real difference for you to classify disease based not on what you see, but on what the surgeon is telling you. Obviously that's not true in the head and neck and else in other subsites. Is that true anywhere else in the body? And does that give you, how do you reconcile that specifically for thyroid here?
Well, as far as the other protocols, I don't have a full, as I'm sitting here, comprehension of the details of those, but I think they're not as involved as what is being proposed here. And I think the anatomic area that the thyroid cancers occur in is much more complicated. And there's, more direct correlation to clinical outcomes based on the anatomic structures that are uniquely involved relative to advanced thyroid cancer. So to answer your question, why thyroid, is I think particularly for those reasons. And relative to the other organ systems, I do not believe there is a need. I could be completely wrong. And it may be specific to individual protocols, organ system-wide, that correlate to the depth of information and granularity that are required here.
But is it a challenge for you if you just put your pathologist hat on, for you to say, I don't see this under the microscope, but I'm going to classify it as such because the surgeon told me he saw it or she saw it?
Well, I'm going to backtrack on that based on what Greg said, because I didn't think about neoadjuvant therapy. We haven't seen a lot of that in relative to now in thyroid. We're seeing more of it in mucosal-based cancers of the head and neck, and we are incorporating that. So you as a surgeon might see dense fibrosis with a quote unquote positive, recurrent laryngeal nerve, and we would need to sample the heck out of that area to make sure that there's any viable tumor. And if not any viable tumor because it's therapy driven, then I would not upgrade that cancer. So I'm modifying my prior comments.
I think that the answer, I forgot what you said, baseline truth or ground zero absolute truth.
Yep.
I don't know if that's obtainable. It's somewhere between the surgical description and the gold standard pathology where the disease is. It's somewhere in between. And that's, I think, the focus of your work is bringing us both together to try and have that not be two separate epicenters, but one truth.
Great. Hey guys, we are up against the 9 o'clock hour. I want to thank both Dr. Wenig, Dr. Randolph, and as always, Dr. Shaha for agreeing to be a part of this and for your astute comments here. Much, much appreciated.